Intraoperative floppy iris syndrome, or IFIS as it is known in short form, is a situation which can be avoided if the information is available before the surgery and patient is started on atropine or parasympathetic ointments. However, here we have a situation where this patient was planned for surgery, and as we can see, the patient has a cataract with a semi-dilated pupil, and this is the fundus photograph, and this is where the surgery has started. At this moment, I was not expecting any IFIS, as this information was not discussed with my counselors, and so patient's information that he may be having IFIS was missing, and so preoperative atropine was also not given. However, some behavior of the iris and the pupil did prompt me that this is something challenging. And here we will see what goes on and how it was managed and what is the outcome. Now, intraoperative floppy iris syndrome is a situation where the iris tissue doesn't have its tone and it's very floppy, and as a result it flutters a lot, and this disturbance, which is created by the turbulent flow of the fluid inside the anterior chamber, causes the pupil gradually to become smaller and smaller. Along with this iris is very free flowing, and it frequently prolapses out of the wound if there is any leakage, and as a result iris tissue is significantly traumatized. It causes loss of pigmentation, it may be damaged, the sphincter may get damaged, and as you can see at this moment, during hydrodissection, when there was fluctuation in anterior chamber pressure, we could see the iris and the pupil fluctuating, and these are signs that this is not a normal behaving iris. However, the surgery was initiated and so it was continued. Entering the anterior chamber, and notice the moment the anterior chamber aspiration is started and there is a fluctuation in the anterior chamber pressure plus turbulence in the anterior chamber, the iris tissue will behave in an unpredictable and a different manner. See, this is what I am talking about. The moment you start aspirating, you find there is a shallowing of the chamber, the iris and the pupil gets smaller, iris tissue flutters, and there is a prolapse into the side port. And repositing this repeatedly will not take care of the situation, because this iris is flowing along with the fluid. So wherever the leaking fluid is going, the iris tissue is following it. However, the pupil, which has become dramatically smaller just at the start of the surgery, has also demonstrated that this is a floppy iris, which is responding just the way a floppy iris would. However, I am continuing the surgery and making direct horizontal chops, multiple chops, segmenting the nucleus into smaller pieces and trying to emulsify them. Now, at this moment, I have options of putting iris hooks, pupillary expansion devices, and continue the surgery. But as I have evolved during my training period and as time has passed, I know that this kind of pupil and this kind of cataract can be well managed with this kind of situation. So we have consumed nearly half of the nucleus and we are proceeding to remove the remaining half. So if you start rotating the remaining half clockwise, there is a distinct advantage. For a right-handed person, the left hand has a side port instrument, and you will keep on chopping and holding the piece which is to be emulsified with the phaco hand piece, so you can simply chop and keep on consuming. So now at this moment we have removed the whole of the nucleus, and you can see the fluttering of the iris, and also along with that the pupil has become progressively smaller. At times I do appreciate and prefer if the iris prolapses a little bit in the side port. Actually, it provides me with a very good dilatation of the pupil in that quadrant, and this provides me good view. Now, using the side port instrument to retract the iris tissue so as to reach around underneath the iris and grabbing the tissue which is needed to be removed is also an excellent strategy which is being demonstrated here. Repositing the iris after closing or shutting down the infusion is important because if your infusion is on, the iris tissue will just not go back. Now at this moment we can appreciate the pupil is something like 3 millimeters in size, maybe 4. Going on for removal of the cortex, and when the anterior chamber is deep, the pupil dilates a little bit, but the moment there is fluid flow which touches the iris tissue, the iris flutters and the pupil goes down. Here we can see how easily the iris tissue gets aspirated by the irrigation aspiration port, and this also causes a meiosis at the same moment. We can appreciate that in the central area where you have visible cortical fibers, you can go ahead and engage them without engaging the iris tissue. That can be a safe strategy. However, at times it is necessary that you have to shift the iris tissue, retract it to see underneath and safely aspirate the cortical matter without threatening iris or the posterior capsule or engaging the anterior capsule. So these maneuvers are important part when it comes to managing the cataracts in these patients who have been on alpha blocker drugs, and there's no other way except that you will have to have patience and availability of tools to peek behind the iris tissue. And this is very much possible that if you are carefully aspirating the cortex, having a good foot control to control the irrigation aspiration and the vacuum, one can easily remove these cataracts and do a safe surgery. The cortex also has been removed thoroughly after visual inspection after pulling the iris away, and now it is time to implant the intraocular lens. One should take care that the iris tissue is never pushed out even with the fluid and also with the viscoelastic. So you start injecting the gel above the iris tissue rather than in the center, which will push the iris to periphery and into the wound. Implanting a hydrophobic monofocal IOL which goes in the bag and then dialing it, rest of it into the bag. We can appreciate the IOL is getting trapped or captured in the pupil because the pupil is smaller than the size of the optic. However, it is dialed successfully, and now it is time to aspirate the viscoelastic gel, and I can appreciate that the pupil has gone down to something like 3 mm to 2.5 ml, which momentarily expands the moment the anterior chamber is deepened. And here I want to demonstrate the iris flutter, which will happen just in a while. When the fluid currents they hit the iris tissue, especially when they go behind the iris tissue starts fluttering the way it is. We can see this, and this is significantly abnormal behavior. We have never seen, usually we don't see such a behavior when we are managing cataracts. And this iris is basically just like a fluid which flutters, moves, and prolapses out through the wound if there is a leak. The dancing iris. This is what comes to my mind by looking at this iris tissue. Stopping the infusion before pulling out and also repositing the iris, and one has to form the chamber and very carefully flush whatever viscoelastic is left behind, and inflating the chamber, taking care there is no iris prolapse, and this surgery is finished. This is the day 1 picture, and we can appreciate it's a good outcome. Patient was also happy. Thank you.